coverage in the existing system. You heard about Medicaid from Andrew's introduction. I'm sure Mr. Rockefeller, if he were alive today, would be glad to know that New York is still #1 by far in per capita or per beneficiary spending on the Medicaid program. And yet Medicaid programs around the country, state programs around the country, are facing real problems of access to care even within Medicaid because the payment rates have been set so low in an effort to try to control costs in the short run that many providers don't even participate, and many beneficiaries have real problems with access to care. And in some ways, the problems aren't any better on the private health insurance side. What many of the private health plans do is sort of follow the lead of Medicare and Medicaid and try in their own way to negotiate lower payment rates with providers, to take steps to try to get prices down or to restrict access to services, like the whole era of managed care, really managed costs in the 1990s. So these are a lot of steps, a lot of efforts, increasingly intense efforts with all the anger and public concern about these issues to try to get some short-term cost savings in health care, but they're really not getting at the underlying problem. These steps to bring down the prices or to restrict access don't do anything directly to improve quality and may actually reduce it. Lowering prices across the board or imposing some broad restrictions on access to certain kinds of treatments in what should be an increasingly personalized and prevention-oriented healthcare system, well, that doesn't do much about the fundamental problems in the way that we're delivering healthcare in this country. Another way of seeing this problem, and another way of seeing why we need a broader approach to thinking about how to get to universal health care, is to remember that spending on health care is prices, what we're paying for services, times the quantities of those services, prices times quantities. And our biggest problem, I'd submit to you, is not that our prices are too high, though there's certainly some more work that we could do on many of those prices. It's getting the right treatments, it's getting the right quantities to the people who need them. And let me give you some examples of this, and I want to start with the path-breaking work done right here at Dartmouth. Since the 1970s, Dartmouth researchers, led by Jack Winberg and more recently people like Elliot Fisher and John Skinner, have done studies showing big variations from area to area around the country in the use of healthcare services and the cost of those healthcare services with no clear relation to outcomes for patients. Costs may vary in Medicare from area to area by 50 or 100% or more, and by hospital treating similar problems by 50 to 100% or more with no clear relationship to health outcomes. That's overuse of medical treatments. Not only that, we have a tremendous amount of underuse of effective medical care in this country as well. This particularly includes our country's poor record of treating chronic diseases. Chronic diseases in this country, diseases like heart disease, heart failure, chronic lung disease, and diabetes account for 75% of all healthcare costs in the United States. You know what our track record is of treating them? It's not